Hi, everyone. Welcome to Ask the Egg Whisperer. Thank you for joining me. Thank you for sending in your questions. Thank you for doing all the work that you're doing to bring more love into your lives. What you're doing, the questions you're asking, it is so worth it. And each and every single one of you, every single person that sends me a question, you literally inspire me. You inspire me to do better, be better, and certainly to never take a single thing in this life for granted. So thank you for doing all of that for me. I know what I do is very selfish. I basically am doing everything I possibly can to help loving people bring more love into this world. It's pretty selfish, I know. So we're going to start off with Brittany's question. So hi, Brittany. Thank you for sending in the question. You said, hi, Dr. Amy, here's our story. I'm 32 years old with DOR with a AMH ranging from 0.4 to 1.1. My husband is 32 years old with mild morphology issues. First stim yielded 3 eggs. First blast that was low-level mosaic, which we transferred, ended in a biochemical pregnancy. Second stim ended with 6 eggs, 2 blasts, both PGS normal. Prior to the second FET, we completed an ERA and Receptiva DX test, which were both normal. Thyroid control with Synthroid, vitamin D, awesome. My BMI is normal. I eat healthy and have eliminated most toxins. We used the same transfer protocol as the first one, PIO, estradiol, baby aspirin, doxy, methylprednisolone 5 days prior. Lining was 11.1, and there was no implantation. We were crushed it would work we were crushed when it didn't work the first time. Is this normal? The RE did have issues with the frozen embryo transfer though. The cervix was not cooperating and they had to exchange the catheter. Could that be the reason? Any advice before our next frozen embryo transfer? I've gone, I don't know what this means actually. So forgive me for taking a moment here. I've gone GFDF per the rec of our RE. I'm not sure what that means. We're doing another round of stims before our next FET. Thank you. So Brittany, here's what I would do. Definitely do that. I would do another round of stims before your next FET. And what I can tell you, even when you've done absolutely everything, sometimes things don't work. So here are the things that I'm thinking of in your situation. Number one, you told me that there was a difficult transfer situation. So ask your doctor, what are we going to do ahead of time to make sure that doesn't happen? So certain things that you can do. You can actually do a mock transfer like ahead of the cycle. So you already did an ERA and Receptiva DX test, so you know they can get in with an embryo biopsy, not embryo, an endometrial biopsy catheter. You know that. And so the question I would want to have answered is, was the doctor who did the biopsy the same doctor as the one who did the transfer? Are they the same person? And if not, maybe see and make sure that the doctor who did the biopsy and who did your first transfer is the same one who does this next transfer. So those are little, things that you can request if possible, so you can coordinate things in that way. The other thing that you would want to ask is, how did the embryo look at the time of transfer? So sometimes you get a report and the report tells you what the quality is, but you also want to make sure that the quality of the embryo on the day of the transfer after it's thawed is consistent with what the report says, because sometimes you get a report that says it's gorgeous, they thought, and actually doesn't look so good. Maybe no one verbalized that to you. So ask for your official cryo report on the day of the transfer, your frozen embryo transfer report. There's always a report generated that describes the embryo quality after it was thawed, so ask for that. And then sometimes people take pictures of the embryo and they hand it to you. So I do that with my patients. And then we also have a video screen up in the transfer room, and we can actually see the embryo. And if I see something about the embryo, I'm going to actually tell a patient and I'll say, you know what, the embryo in the picture, from when it was thawed 2 hours ago, and then comparing it to the screen up there, it doesn't look like it's expanding as well as I would expect. And it's not growing in the way that makes me feel like that you have, this percentage chance of pregnancy that we had discussed early on. So I want to let you know that up front. So I have that mnemonic, embryodiamonds.com. You go to that website and then make sure you've gone through everything there and talk to your doctor about the quality of your embryos, the implantation rate of what they were expecting. Because one of the most common reasons for a transfer not working is because of the embryo. It's either the embryo or the lining or some sort of, interaction between the two, and the embryo not being as good quality as the mosaic embryo, for example, could be a reason. I'm also wondering why you transferred the mosaic first. Perhaps it was because, that was the first cycle you did, so that makes perfect sense. And then you did the second cycle and you got 2 blasts and both were normal. And I'm so glad that you still have one left. And then I would say, maybe looking at a saline sonogram again. It seems like you did the ERA and Receptiva that were both normal. Make sure you have all the official reports and kind of talk to your doctor about that. And then double check everything. Make sure that the amount of progesterone that they put you on for the transfer was the exact same. And then, you did have a transfer success with the first cycle, meaning you had a biochemical. So maybe compare that protocol with the protocol that you did more recently and see, what the differences are, and just be super nitpicky about everything. So thank you for answering these questions, or for asking these questions. So this next question comes from Mina. Mina says, "Hi, Dr. Amy." Insert all the usual high praise here. That's very sweet. "I'm turning 35 next month. I had my AMH tested and it's 1.06. I have PCOS. I've done 2 retrievals 3 years apart and I got 11 eggs the first time, 9 the second time. Although I was able to create 7 genetically normal embryos, I've had 3 transfers that all failed. I used my embryos that were best first. Now I'm left with a 4BC, 4BB, 3BA, 3BC. ERA was receptive, H score normal, adding prednisone to the next transfer and putting in 2. I'm a disaster planner, so if this doesn't work, what do I do? I feel like my biological clock is ticking louder than ever. Please help." Okay, Mina, you're 35 years old. You just told me a really good story that you make these beautiful embryos that are genetically normal. My concern is that you've had 3 transfers that have all failed. You have 2 really good embryos left. The others aren't as good quality. Do another stim cycle now. I know. It's like, what? Why would I do another stim cycle now? I'm just worried that you're going to transfer your next best embryos and you're going to find out that maybe it would make sense. Or let's just be positive, Amy here. And let's say you transfer 2 embryos, 1 takes, and then in 2 years from now, you're ready for your second baby, and the embryos, based on the quality, they won't give you more than a 50% chance potentially of turning into a healthy pregnancy. And then you're going to say to yourself, like, why didn't I do another egg retrieval while I still had healthy eggs? So that's why I'm thinking it might feel better going into another transfer knowing that you have embryos waiting for you. It sounds like you have probably done every single implantation test I can imagine, but with 3 embryo transfers that haven't worked, sometimes you can try different protocols, and it sounds like your doctor is adding prednisone, but think about doing the Lupron Femera protocols. There's a protocol for people with what I like to call implantation issues. And sometimes you don't have a piece of paper that says, like, this is what is wrong. I mean, a lot of times you don't. And you just have these real life experiences that tell you what you should be considering next. So in your situation, it might be helpful to consider maybe 1 month of Depo-Lupron overlapping with Femera. There's a protocol for that that's been studied and published in the literature showing that people who do that 1 or 2 months have a higher implantation rate potentially than, compared to people who have implantation issues who don't do that. So that might be something for you guys to consider next. Okay, so this next question is from Sarah. Sarah says, "Hi, amazing Dr. Amy. I've been trying to conceive for 4 years. I have lean PCOS, absent periods, and also recently was diagnosed with endometriosis via laparoscopy. I've had multiple IUIs, 2 early miscarriages, 2 short IVF cycles with lots of eggs retrieved, and only 1 poor embryo to show for it. Most recent IVF, I only had 1 egg fertilized after 16 retrieved. My doctor has said it's an egg quality issue and suggested an egg donor, and I'm 33 years old, high AMH, husband's 34, and I've done every single test. I've taken all the right supplements. His sperm is perfect. We had a pregnancy 10 years ago, which I terminated. My sister's ready to donate, but I'm not quite ready to give up on my eggs. My doctor said we should try a long cycle, 2 months of Zoladex or the opposite, a mini IVF cycle as a more gentle approach. I have 2 cycles left in me to try before moving to donor. What do you suggest? I could try a protocol. I'm looking for a protocol to improve on embryo outcome. We don't have HGH available in my country. I'm messaging you from New Zealand. Thank you." So Sarah, here's what I would say in your situation. There are still things that you could potentially do that we have here as well. So you've probably heard me talk about NAD, so you can definitely get that and start taking that immediately. You do have access to a sperm DNA fragmentation test, so I strongly recommend that you consider doing sperm DNA fragmentation testing. I know your doctor is saying egg because sperm looks sparkly and fabulous, but at the same time, I don't want to miss something. So I've had situations where the sperm actually looks good, and then you do the sperm DNA fragmentation testing, and then you find out that actually the DNA fragmentation was really high despite having a really good semen analysis. So I would definitely do that. The other thing is you have to allow the miscarriages that you had to pave the way and kind of teach you something about what's going on with yourself. So with the 2 miscarriages, I would make sure that you have both done chromosome analysis, because if you have a translocation, then perhaps that could explain the fact that you're having such low fertilization rate and a low blast formation rate with the one poor quality blast that you did make. So that's something that would help guide you, because if that were the case, you might want to consider using your sister as a donor. Regardless, you can put her through. I mean, the way I think about it is, depending on how many kids you want, you can still do parallel path, meaning you can still work with her as far as making embryos and have her be your donor now. And then you can still at the same time do another cycle for your own eggs. So you don't have to feel like you can't do both, but preserving her eggs for you with embryos would be something that you can, use in the future. Let's say you're only 33. Let's say when you're 39 or 40 and you're ready for your second or third baby, then you can use those embryos at that point. But for now, it still would make sense, given the fact that you've done 2 cycles and you already told us that you still have 2 more cycles left in you. So I would say go for it. Consider, let's say, a mini IVF protocol. Consider, your doctor said they want to try a long cycle with 2 months of Zoladex, and I wonder if perhaps they think you might have endometriosis. So endometriosis can cause your egg quality to be lower than what would be expected at your age, but at the same time, you mentioned that you have a lot of eggs and your follicle counts are really, really good. So I would also make sure that you've ruled out PCOS and that you've actually looked at all the metabolic parameters that are associated with it, including hormones like testosterone. And if your testosterone is high, I'd like you to make sure that before you do another cycle, you've treated it. So another supplement to consider taking would be something like Ovasitol. You can get that from Theralogics.com, and you can use my PRC code, which, surprise, surprise, is Tushy, all caps, TUSHY. Alternatively, there are a number of products out there that have inositol, myo-inositol, dechiroinositol that can also potentially help lower your testosterone levels naturally. And if your doctor thinks you need something like metformin, consider taking that too. So I do like the idea of a mini IVF protocol as well, especially if they're getting a lot of eggs. And when I say a lot, if they're retrieving like over 20 eggs and your estrogen levels are, in the thousands, then perhaps taking a different approach might help. This next question comes from Mehar. Mehar says, recent reports showed anti-nuclear antibody and titer greater than 1 to 640. So that's the ANA level. Tests for double-strand DNA, ENA, PT, PTT, INR, all negative, meaning lupus anticoagulant negative. How serious is an abnormal ANA? What does this exactly mean? My doctor said I don't need any further testing, but no answers were given on why my ANA is abnormal. Do they rule out everything? I feel they need to do more immunology tests. Can you explain which ones I should be doing? What should be my next step? I've had 2 miscarriages in the past year. So Mahar, this is the thing. I would say seeing a rheumatologist would make the most sense. They'll go through your history, your family history, see if you have any joint pains, for example, see if you need to have other testing done. It sounds like perhaps you're working with your IVF doctor, and I like to just defer patients to the experts in whatever the situation is. So if you're worried, I think it makes sense to see an expert in rheumatology to see if they can rule out anything in your situation. And if everything is negative, then I would seriously say it's just not a very sensitive test, and it doesn't really tell us that anything is wrong. The 2 miscarriages might have something to do with age, anatomy, genetics. So make sure you've gone through angelmethod.com, looking at your age and the number of miscarriages you've had. Talk to your doctor about a treatment that will help you have the family size that you want, starting at the age that you are. And I know you've started before now. I know this isn't your first time saying, oh, I'm ready to have a family. You've been through so much already. But by talking to a fertility doctor that knows your diagnosis and what you've been through and really looks at everything, including your goals, is really helpful and I think useful. This next question comes from Stephanie, and Stephanie says, hi, Dr. Amy. I just needed some advice on tips for my situation. My husband is 42, no fertility issues. I'm 37 with unexplained fertility issues. We've done 2 IVF cycles at 2 different clinics. In my first cycle, I was 34 years old. This was in 2017. I had 14 eggs retrieved and 5 made it to day 5 as frozen embryos. I then had 2 biochemical pregnancies and 2 miscarriages. The last one didn't implant at all. Our second IVF cycle was December of 2020, and it was a fail. And we got 4 eggs retrieved, and none made it to even day 2. It was heartbreaking as we thought this clinic was going to be the one and heard lots of success stories. Now we're on to a 3rd clinic, going through a 3rd round of IVF and haven't started anything just yet. I just wanted a break for a month or 2. Any advice on our situation? I do have hypothyroidism. I do have a fibroid, but it's on the outside of my uterus. So Stephanie, here's the story. So we know that your story is an egg story. It's a really, really common story that we hear quite a bit. So the explanation is age. So at 37 years old, what you've experienced is super, super normal. This is not a mystery. And I know, like most 37-year-olds walking in here, I mean, they're feeling great, they feel energetic, they feel young, they don't feel like their eggs should be old. And it's just so incredibly unfair that despite feeling that way on the outside, our eggs have a different story for us on the inside. And you don't know it until you go through this, the real life experiences that you've had. So what I'm wondering is, have you gone through everything in the angel workup? Have you ruled out, let's say, a balanced translocation? Has your doctor looked at things like a fragile X screen, for example? And I already mentioned the chromosome analysis, but it seems like we're dealing with potentially a lower egg count now, since the egg count was 4 versus 17, almost 4 years ago. And I feel like, there's still a chance, trying HGH, the egg quality supplements, different approaches to IVF, like a mini IVF protocol, for example, and looking at different starting points in your cycle to start them could all be strategies that could potentially help you. But at the end of the day, given what we've learned, given the diagnosis, this is an issue that sometimes we can't overcome, no matter how smart you are. Of course, it has nothing to do with that. Where you went to school, which doctor you're going to. We just sometimes can't overcome the things that, biology presents us. And I really wish that I could, because that would be awesome to help every single person the way they originally envisioned having their family. But I think what would be helpful for you, and what I would tell you if you were a patient of mine, I would say, let's just talk about what we would do if this next cycle didn't work. And if this next cycle didn't work, sometimes you would do that before you even did another cycle. And what I mean by that is, maybe it's time to talk about embryo donation, egg donation, and adoption. There are so many amazing ways of being a mother. And while we really want it to be with our own DNA, you're so young at 37, you've already spent the last 4 years trying with IVF. And I think because of the diagnosis, we now know that there is a chance that we can't overcome this egg quality issue because of age. And if you can't, then just know that your heart, while it's normal to feel grief and just devastation over the fact that it might not be something that you could achieve with your own eggs, your heart won't know the difference between your genes or someone else's genes once you're holding that baby in your arms. And I know that that's really hard for people to see for themselves, but I see that with my patients all the time in cases just like yours. And certainly I'm not giving up on your own eggs, girl. I'm the most competitive person in the whole world. So you still haven't done all the Amy sauce before you do your next cycle. So consider that. Okay, this next question comes from Melissa. Melissa says, is it possible to ovulate late after an HCG trigger shot and IUI treatment? For example, I did Femara 7.5 milligrams for 5 days. I triggered on day 12. I did my IUI on day 14. I had negative home pregnancy test, day 29 to 31. The IUI didn't work, no period for another 9 days. Then I tested on cycle day 39 and I got a positive HCG. My HCG on day 41 was 1636. 3 days later, it was 3750, went for an early ultrasound at 7 weeks 1 day, and there was no fetal pull. The gestational sac and yolk sac measured 5 weeks 6 days, and the HCG this day was over 14,000. Is it possible I conceived after IUI or on our own? Do you have any advice? So Melissa, what I would say is it's very possible their HCG levels were really, really low. Like they started at 3 and then went to 7 and then they went to 13, and then over time a sac grew. So it's probably from the IUI pregnancy. However, it's really sad, and I'm sorry that you had that experience. So in a case like this, what I would advise is allow that pregnancy to teach you something, to teach you what happened. Get that piece of paper if you can to find out if the pregnancy was genetically abnormal or not. If it was genetically abnormal, then you have some decisions to make as far as whether you should do, for example, IVF with genetic testing at your age. If it was genetically abnormal, then you would know if you should look at other things like the anatomy of your uterus a little bit more closely. If you should be, let's say, thinking about, a thrombophilia workup or looking for antiphospholipid antibody syndrome and ruling that out. So I hope this advice is helpful. And at the end of the day, the fact that you got pregnant, of course, that's a really good thing and it's a good sign. But I still feel like even when someone has had one miscarriage, for me, I just go to my checklist. One is enough. Like, I'm not going to wait for someone to have 3 miscarriages to then be like, oh, did you know that there's tests that you can do to figure this out? It kind of drives me slightly bonkers when a patient tells me they've had 3 miscarriages and they ask their doctor every single time to do genetic testing on the pregnancy, and the doctor said, no, you had to have at least 3 or more, and now they're finally going to let you do testing after the third one, and it's like, oh man, that's just really not what I think that we should do and how we should offer miscarriage care to patients. So this next question is from Mary, and Mary says, "Hi, Dr. Amy. Thanks for helping us. I love your show. I'll be 41 in June. Between the ages of 39 and 40, I've frozen 18 mature eggs. How many good embryos could I get with that number?" Okay, here's the deal. So you're 39. Let's just make it easy on me. You're 40. So you have 18 mature eggs. So 18 mature eggs, I'm hoping that you could get about 1.5 genetically normal embryos. And you're just like, what? I know, it's nuts. So if you were to, it's not necessarily 1 in 10 eggs will have normal genetics, but on average it's like that. I wish it could be like, oh, you have 10 eggs. That means you'll get 1 normal embryo out of it. But it's not as good as that. So good job with that. And I would actually say if you have it in you to do 2 more, I'm not sure how many egg retrievals it took you to get 18 mature eggs, but if you still had it in you to do it again or to make embryos now at 41, that's something that I would be talking to you about if you were my patient. And take CoQ10 if you're not taking it already. This question comes from Diana. And Diana says, "I'm 38 years old, about to start my 3rd frozen embryo transfer. My first natural cycle, normal PGT, perfect pregnancy, had no heartbeat at 13 weeks. My ERA was pre-receptive. The fetal test showed everything was normal. The second FET stopped at 7 weeks. No PGT. In the 3rd cycle, let's see here, no PGT. My protocol has not changed. Depo Lupron on day 19, then for 10 days in a new cycle with a transfer 11 days after the last shot of Lupron. Also estrogen and progesterone 3 times a day. Would you recommend anything different? Should I move my transfer 30 days back to allow Lupron to leave my body? Thank you." So Diana, that's really sad, and I'm really, really sorry. And a lot of places use Depo-Lupron to prevent ovulation, and as long as you're taking estrogen and progesterone, you don't necessarily need to wait for the Depo-Lupron to come out of your system before you transfer. However, if your gut is, I should wait for it to come out of my system, then I would say, please listen to your body and ask your doctor to just wait 30 days. So my strategy is to wait until the 30-day mark after Depo-Lupron shot and then start estrogen and transfer about 3 weeks later. But there are different reasons why people use it. So that is one way of using it, overlapping with your estrogen and progesterone as well, and for the purpose of preventing you from ovulating during the cycle. So if you haven't already, consider the Receptiva DX test. It sounds like Depo-Lupron would treat any possible inflammation, but sometimes it's not enough. Maybe you need 2 or 3 months. And the other thing is look at your fallopian tubes and see if there's any hydrosalpinx. Ask your doctor, have you ruled out adenomyosis? Because adenomyosis and severe endometriosis can cause these kinds of issues as well. And I would say, I'm not sure how many embryos you have left, but I would strongly consider doing another cycle of IVF before you transfer again. And then I think I probably already said to look at the cavity and do a hysteroscopy, saline sonogram, HSG, something like that, to look at the cavity a little bit more closely. Another thing I do is, is think a little bit outside the box and look at immune testing. And when I say immune testing is if you know you're having transfers with genetically normal embryos that aren't working and everything has been ruled out, that might be a good time to do some extra testing like the HLA-KR testing that I've talked about before. Okay, so this next question is from Rachel. And Rachel says, "Hi, Dr. Amy, do you typically increase dosages during stim, or do you suggest staying at the same dosage but stimming longer? I'm a poor responder and sometimes changing things mid-cycle messes me up, but my doctor suggests bumping my gonal from 300 to 375 and continuing HCG at 30. I typically stim at 200 of gonal and 20 of HCG. Can bumping up the dosage throw a cycle off, or do you suggest slow and steady wins the race? Thank you." So Rachel, I bring patients in for their monitoring for a reason, so they can make adjustments. I don't think making adjustments will throw your cycle off. So you guys, I have this method. It's called the Sparkle method. Size of the follicles, protocol, are you happy? When's the retrieval going to be? Are we going to keep going? What does the lining look like? And what are my estrogen levels? I know, I just rattled off a whole bunch of stuff, but if you literally go to sparklemethod.com, you're going to see exactly what I'm talking about all outlined there. For those of you who are watching this who've never done IVF before, those are the SPARKLE, the 7 things that I want people to know with each visit in my clinic when they're doing IVF. And I tell you that stuff all the time if you're a patient here, but I'm just surprised when patients come to me for second and third opinion consults, they didn't know that that information was something that they could have so they can understand what's happening as you're going through the cycle. So you ask a really good question as far as changing the protocol. And I actually look at the follicle sizes, I look at the hormone levels, and then I make a decision as to whether we should change the protocol or not. And I describe what I'm looking for, why I'm changing things, and what I expect next time when I see you. So depending on the number of eggs that you have, if you truly are a poor responder, some of the things that I think about are, avoiding suppressing medications like estrase priming, avoiding birth control pills. Sometimes that can help with poor responders. The other thing to consider doing is rather than starting straight injections, perhaps do a combination of pills and shots. And your dose is actually not a super high dose. So potentially you actually need a higher dose from the very beginning. So rather than starting at 300 units, start at 375 at the very beginning, rather than playing catch up later. Okay, this next question comes from Lindsay. And Lindsay is saying, hi. Hi. Okay. Wondering your thoughts of my husband and I getting pregnant naturally. Here's the deal. My doctor says we need IVF, but there's a male fertility specialist that says we'll be fine on our own. We just want one baby. I'm 32 years old. My AMH is 3, my FSH is 7, my thyroid's normal. We had a miscarriage at 6 weeks, 5 days with a DNC in July 2019 and a pregnancy of unknown location treated with methotrexate in November of 2019. My HCG was only 850. I was having pain, so they treated it as an ectopic, but then saw I had a very large complex cyst that was probably causing the pain. I had a saline sonogram, and my saline sonogram revealed I had a septum, which was removed in July of 2020. My periods are super normal, full lab workup, no clotting factors. My husband's sperm is the following. Total mobile count 156 million, concentration 68 million per cc, morphology 1.5%, grade 2 varicocele, but DNA fragmentation was 15%. We both lead a very healthy lifestyle and are taking prenatals and CoQ10. Okay, so Lindsay, it sounds like you've probably also had a hysterosalpingogram. So I would make sure you've done a hysterosalpingogram recently. Look at the fallopian tubes and make sure they're both open. I think that's really important. It sounds like you did not have an ectopic. I agree with you. So here's the deal. It sounds like you've kind of done everything possible to give yourself the best chance of getting pregnant naturally, and you know a lot about yourselves. His sperm morphology is a little bit on the low side. Only 1.5% of the sperm cells have normally shaped bodies. When I say bodies, I'm referring to head, neck, and tail. So if a sperm cell is not shaped normally, the egg is going to be like, you're not coming here. No, you're not. I'm not giving you a rose. So that makes the diagnosis a fertilization issue. Since his count is so good, sometimes doctors say, oh, his count is so good, the morphology is low, you don't have to worry about it. But sometimes you do. And so I know you had the DNA fragmentation that was good at 15%, but I still wouldn't use that as the green light. All is good. Don't worry about anything, and you should get pregnant naturally without any help. But I don't think you necessarily need IVF. My suggestion is to consider IUI, especially since you just want one baby. Given your high egg counts, you might have a lot of unused embryos. But at the same time, the history of the 2 miscarriages makes me think that there could be an egg quality issue, but then you threw in that you had a septum removed. So not so fast, Amy. So my suggestion is to see a doctor who has access or who will consider using the Zymot fertility chip. I swear that thing is magic. They should pay me, and they actually don't. They actually charge me like full price for the Zymot fertility chips, literally, and that's because I don't know why. Maybe I should ask them to give me a discount. They're about $150 per chip, and basically running them through the chip at the end, it's kind of like a little obstacle course for the sperm cells. Well, not really. And at the end, the best swimmers will basically be there for you to pick up and put at the top of the uterus. So I think potentially that could be something that might benefit you before you go on and do IVF. And if you end up doing IVF, you can still use that chip. You can also do PICSI, and I have a feeling that the urologist that you saw would agree with what I'm saying, that you probably could still get pregnant naturally. You've done it before, twice actually. And now that the septum is removed, I feel like you probably have a pretty good chance of getting pregnant again. And make sure you guys are both taking CoQ10. This next question comes from Lee, and Lee says, hi, Dr. Amy, I just got my Receptiva score back and it's 1.6. Normal score is 1.4. Is this result too borderline to be conclusive? Could it indicate an extremely mild case of endometriosis? I don't have anything else. I don't have endometritis or hydrosalpinx. When I was much younger, I went on birth control pills. I would get really bad periods, and I went off birth control pills, and then the severe periods never came back. If this is an extremely mild case, would something like Depo-Lupron still be necessary? Are there other treatment options? I did this test because I only have one PGT tested embryos, not because I failed to transfer, though I had 2 biochemicals with IUI. Thank you so much. Okay, Lee, so I'm so curious as to why you had the 2 biochemicals with IUI. It sounds like you ruled out a hydrosalpinx because I bet you did an updated HSG. If your HSG was like 2 or 3 years ago, do it again. I've been surprised, like, I get floored. It's like, you got pregnant, you had biochemicals, your HSG was normal back then, and then now it's like 2 years later or however long it is, and now you have a hydrosalpinx. And it's like, huh? So don't rely on old data to guide you today. Repeat that HSG if it's been a year since you've had it done, just to make 1,000% sure that there's no hydrosalpinx. So it sounds like you don't need surgery. It sounds like Depo-Lupron might be too much. So maybe consider what I would do for a patient just like you. So what I would do for you is I would have you go through your cycle of FET meds, but have you take 2 tablets of Femara just for 5 nights in the very beginning. So that's one way of dealing with the BCL6 level that works really, really well. By doing that, you're reducing the BCL6 level. How do I know? Because I have put people through repeat biopsies. I have. They've had a mock cycle with me, and then I'm like, I don't believe it. I don't believe it. And then I put them, what I'm saying is I don't believe I treated it. So I actually put them through the treatment, and then I do another biopsy. And so that's how I know that Femara works. And I also know because it's worked because I've put patients on it and they get pregnant and it works. This next question is from Karen. Karen says, thank you for this podcast. I'm 39 and my husband is 31. We started fertility treatment 7 months ago after trying to conceive for 10 months. My AMH is 0.17, my FSH is 10.8, and my estradiol is 60. I have at least 6 follicles at each baseline. I've had 1 round of IUI, 1 counsel round of IVF, 1 successful round of IVF, which yielded 3 eggs, 3 fertilized, and 1 day 5 euploid blast. Unfortunately, the transfer was unsuccessful, but I've never had symptoms of endo. I have an endometrioma on my left ovary. I'm in my 3rd round of IVF with a retrieval this weekend that will yield 1 or 2 follicles. I've been diagnosed with low AMH, low egg reserve, and my experience has shown that we can make good embryos. We would love to have 2 kids and would love to know your advice what to do next. A bunch of IUIs, many IVF. What can I do to increase the odds that my next euploid implants? Thank you. So Karen, I would just go with the egg whisperer plan. Let's break it down. Diagnosis. We know that you have endometriosis. We know it because you have a big endometrium on your ovary. We also know that you have lower egg quality just because your AMH is low, but certainly we've obviously proven that you can make a normal embryo, which is awesome. So we know that you would love to have 2 kids. So my recommendation for you, given your age of 39 and your low AMH, is to do all the work right now upfront to create more embryos to bank for your future. And also have a really honest talk with with yourself and be like, look, there's a chance that I might need to use an egg donor for the second. I just think it's just good to kind of just talk these things out and see how they make you feel and say, what am I going to do if I can't achieve another normal embryo with my own eggs? What am I going to do if I transfer again and this doesn't work? I mean, it's just overwhelming when you're in that moment and to have that experience, as I'm sure you felt. So I feel like having those conversations now with a therapist, with your husband, with a therapist again, with your husband again, and just putting it all out there so you feel less overwhelmed, in that way. And then you pick your mantra, and you guys hear my mantra all the time, not for myself, you know what I mean, but I'm going to be a mother one way or another. My mantra is I'm going to help you be a mother one way or another. That's kind of what I say all day long for my patients. And it's going to be okay. And it's never the end. There's always a chance. There's always a way. There's always something else we can do to help people. So my thought process is to do the ERA. So I was just talking way too much. So IVF with all the stuff that I talk to you guys about all the time. So consider adding HGH, all the egg quality supplements, and then the E part of the diet, right? So diagnosis, IVF. The E is we know the diagnosis, and so we want to make sure the embryo transfer prep is part of that. So do the ERA test. I would expect that, or I would think that your doctor would probably bring that up at this point, given the 2 transfers that it looks like they didn't work. And then consider 1 or 2. And then I would consider doing the Receptiva DX as well. And then you can see if your doctor thinks that doing a laparoscopy would make sense. But if you were a patient of mine, Karen, I would tell you to consider doing a laparoscopy, hysteroscopy before another transfer, just given everything that you've been through so far. And I really hope that your next cycle of IVF is successful and you get a number of at least 2 embryos that have normal chromosomes, or at least 1 obviously would be awesome and amazing. But I feel like a bunch of IUIs could certainly be done and done later, but right now would be the best time to consider doing more IVF. Okay, this next question comes from Ruth. I'm 35 years old and I had endometriosis stage 1, excision surgery 5 months ago. I've also had 4 myomectomies for fibroids. I live in near constant severe pain for many years before that surgery. Now I have no pain at all, which is great. I want to freeze my eggs after a recent breakup, but I'm concerned about bringing my endometriosis, that it would bring back my endometriosis pain, as I know the hormones can do that. My fertility doctor said that this is a real risk, but she can't tell me how likely it is. She also notes that endo can come back anyways, even if I don't do the egg freezing. My AMH is high at 6.52 since I have PCOS. My RE says she would use a very low dose of gonadotropins and then Lupron to trigger to mitigate OHSS risk. She said that using lower doses of hormones would also mitigate the potential endometriosis growth. What would you advise? So Ruth, thank you for asking this question. This is something that I deal with all the time. I deal with patients who have endometriosis, fibroids, PCOS, so we can handle all of this. We got this. Let me tell you what I would do in a case like yours. Number 1, periods are the enemy. What I mean by that is potentially consider taking birth control pills continuously or using something like an IUD until you're ready to have kids. This can prevent the progression and growth of endometriosis. 2, N-Acetyl Cysteine. Take it. Consider taking it all the time. This can also reduce the progression and chance that endometriosis can come back. 3, CoQ10 until you're done having babies. Thank you. And number 4, I would definitely freeze your eggs. The way I would do it if you were a patient of mine is while you're on stimulation, I would actually have you take Femera, 2 tablets per night every single night. And that will also decrease the exposure of estrogen to your cells in your body and hopefully would also prevent stimulation of endometriosis. But I feel like we know that endometriosis can affect your egg quality. It can make the age of your eggs act older than your chronological age. And if that's the case, this is the perfect time for you to freeze them because we know that endometriosis can still come back. So I would say your doctor sounds like they know exactly what they're doing as far as how they're going to stimulate you. Low dose, get seen early and frequently, and then trigger with Lupron, and then hopefully you'll get gorgeous sparkling eggs that you might never need. And if you need them, you're going to be so glad that you had eggs on ice. So thank you guys for joining me on Ask the Egg Whisperer today. I really love, I wish I could say, listening to you and hearing your questions, but I love the fact that we have technology where you can send me questions through asktheeggwhisperer.com and then I can read them to everybody so people can feel a little bit less alone and people can relate to the things that people are sending me questions about and say things like, oh wow, like that's the experience people are having when they're going through fertility treatment. Because I think there's this misunderstanding that IVF is one and done. I mean, I really try and make it one and done. Believe me, I work so hard to do that. But some people's journeys take a little bit longer. And I hate journeys. I love paths. I just like to go from A to B. I don't like to go to A from A to Z to Q to R to S to B. That's no fun. So I'm just going to spend a couple minutes going through your live chatted questions, and then I have to run home and then call 3 people to review their instructions. Let's see here. Hi, Dr. A. I'm 6 days post 5-day transfer, tested at home today, and it's negative. I'm out. Am I out, or could HCG still be too low to show up? My beta day is day 10. So the answer is you're still not out. There's still a chance. So wait a couple more days to get to do another test. Is ERA still beneficial for someone who implanted but miscarried at 6 weeks? I don't know. I mean, the ERA folks would say potentially, but my gut is that you probably don't need the ERA test. I think maybe doing the Receptiva test would be helpful to see if there's endometritis, endometriosis, or a microscopic polyp. Next question here is, can you please do a video on a dermoid cyst in the ovary? Is it okay to do IVF with this cyst? So the thing is that dermoids are almost always benign. Sometimes they can increase your risk of having something called ovarian torsion. Going into a dermoid cyst can also cause something called tubal scarring because the stuff that's in there is like Elmer's glue almost. And so if you open it up and don't have it opened up by a surgeon that's really, really good, even a really, really good surgeon this can happen to, then you might get scarring of the fallopian tubes and it can be harder to get pregnant naturally. So doing IVF with a dermoid is totally doable. A lot of people have dermoids. Like I said, they're almost always benign, but your doctor would know if you should have it removed first. Let's see here. Is sperm DNA fragmentation level of 25 good enough to yield good blastocysts? The answer is yes. For me, I worry when the DNA fragmentation is way over 30, but there are tools that we can use now like Zymot and Pixie that can potentially help. How do you help patients decide between a fresh versus a frozen donor? Easy. Which one do you like? It's as simple as that. You want to pick a donor that you're like, I am super excited to work with this set of eggs. And if you haven't found that donor in a frozen egg bank, then start looking fresh. Someone's asking, can you get your period 3 weeks early? I have been applying heat through Moxa and I'm preparing for my stimulation cycle. Thanks. And the answer is yes. Periods can come anytime, and you can get a period 3 weeks early, and that can usually mean that you had a cyst on your ovary that resolved, your estrogen level dropped, and then your period started. So it doesn't necessarily mean that there's anything wrong with you, but make sure you've done an updated FSH, estradiol, and AMH to see what's going on. And also make sure that period actually isn't a polyp that's just causing a little trouble and trying to get your attention. Sabrina's asking, do you think the ERA is necessary? And my answer to you, Sabrina, is I think it's necessary to talk about the ERA. I don't think it's necessary to do it. I don't think everyone needs it, but I think it's necessary to talk about so people know what their options are and then they can choose whether they want to do it or not before their first transfer. What's an antagonist protocol? So that's when you use a medication called an antagonist to prevent ovulation. I've had my first FET that failed. My embryo was a PGT tested embryo and I have 6 embryos left. Should I do another transfer in ERA first? So if you have 6 embryos left, I would use the quality to guide you. The mistake people make sometimes is they actually use their best quality embryos to transfer first and then they do the ERA, and by the time they get those results back, now they have like 3 really low quality embryos, for example. I don't want you to be in that situation. So use the embryo ranking to tell you whether you should be doing it, yes or no. Take a look at the number of embryos that you have that will give you a 65% chance or higher to become a mother. And then take the number of kids that you want, put that information together, and then see if you should do the ERA now or later. Because it would suck to have to do another IVF cycle because at the end of the day, no one really wants to do that. It would be nice to get it done the first time. Next question is, my estradiol is 33, LH is 5.7, FSH is 6.5, TSH is 3.6. I do ovulate because my BBT goes up. Can that TSH level prevent me from conceiving naturally? And the answer is probably not. 3.6 is pretty darn normal. I always repeat the TSH. If it's still high, then do a complete thyroid profile. And then depending on what's going on, maybe just give you a whiff of thyroid hormone and have you see a medical endocrinologist. Next question, age 39, AFC 1 to 2, AMH 0.06, FSH 13, perfectly healthy. 2 failed IVFs, failed at stim stages as I didn't respond to meds, Follistim 450. Am I fooling myself trying with my own eggs? And the answer is you're not fooling yourself. Hope never killed anybody. It's totally okay to have hope. Have only positive and practical expectations is what I call hope around here. So what makes you human is you're positive and you have hope and you're really excited about being a mom. And it sounds like you're being very, very realistic. And I would say, give yourself a timeline. Be like, hey, if I'm not pregnant by June, then I'm going to consider an egg donor, embryo donor, or other options, right? I mean, I think that's perfectly fair to do. Let's see here. Okay, you guys, I'm going to take off. It has been awesome being on here with Ask the Egg Whisperer. Love you guys. Love every single one of you. And I will be here again probably tomorrow night. Okay, so love you guys. Have a wonderful night. And my heart beats for each and every single one of you. Each of your stories stays with me, literally, and I literally all day long hope and pray for every single person who reaches out to me and everyone around the world suffering to have less pain throughout this process. So I hope that by sharing these stories and just kind of talking about this kind of stuff will remove a lot of the stigma that a lot of people feel. We should be talking about this and talking more about this and realizing with all the questions I'm getting, I don't think you guys realize like how many questions I actually get every single day. This is quite a common thing that people are going through. A lot of people are dealing with fertility issues. So I'm glad that we can build this community and I can answer these questions for you guys. So thank you all. I love you. Bye guys.